Hi, everyone. How are you? Hope you enjoyed the keynote speaker. I know I did. Welcome again to the AvaSure Symposium 2021. I'm Stacy Overholt, and I'm the Director of Clinical Program Success at AvaSure. And today I look forward to presenting some of my favorite and key best practices for achieving your return on your investment of your telesitter program. I have 15 minutes to do this because this is a lunch bite. So hopefully you're eating some lunch and getting some nutrients in. But this topic could be talked about for much, much longer than 15 minutes. So I'm really going to focus on some key strategies to keep in your mind as you either build and implement and design your program, or as you continue to manage an existing program. So I'm going to keep it pretty high level, but just know that the AvaSure support team is always available to help you. We've got a really strong clinical team. And if you have any more detailed questions, we'll certainly be able to answer those in the weeks coming if you connect with us. With that, I'm going to turn on a PowerPoint presentation and start presenting. If you have questions, feel free to use the question and answer chat, and we will go through those at the end of the presentation. So let me get this going here. Oh, just a second. All right. All right, does that look okay? I want to make sure everybody can see that. Okay, I'm going to go ahead and jump in. So we're going to talk about how to achieve a return on investment on your AvaSure investment. So there are 5 keys, I believe, to success for this. Really want to focus on the many happy returns of telesitting, and want to really break this down into a couple of different categories. So the categories we're going to talk about today and the returns of telesitting are going to impact you and your healthcare facility and your patients in many ways. Of course, safety, people, quality, and cost. So really, when you look at safety, you're looking to avoid bad events. Obviously, you don't want your patients to become harmed. You don't want your staff to become harmed. And so one of the returns of telesitting is, of course, improved safety. Another return is the satisfaction of the people. You're going to impact not only your patients, but your patients' family members and your staff with the use of telesitting. You're going to allow for a safe environment. You're going to allow your patients to feel paid attention to. You're going to help your nurses with a second set of eye. You're going to decrease the stress at the bedside. So people is a very important impact here. Another return of the telesitting program is going to be quality. Of course, getting the job done, making sure you're working to do things well. Telesitting can create those efficiencies for you, can be an assistant in rounding, in check-ins. Imagine what a camera can do in a room with an environment check. You'll have a reminder that maybe the bed rails aren't up appropriately or things like that. So that quality of care is going to be impacted. And then finally, cost. Really, this is the impact of the expenses of the interventions that you're providing right now and the work to decrease those. So those might be costs of sitters, or it might be the costs associated with falls and patient harm. But those are some of the returns you're going to see from your telesitting program. I want to focus this discussion today on 5 keys to achieving these returns on your investment. So you've made this decision, or you're making a decision to purchase a telesitting program. And when you're looking at that, you've probably estimated or presented to your financial team an ROI or a proposed ROI that allows a decision to be made to purchase this. Once that is submitted and you're going to be purchasing this system, how do you actually get that ROI? I do not want you to think that this technology can be brought into a hospital, plugged in, turned on, and you're on your way to your ROI. It takes time, it takes effort, in order to be successful. And that is what I'm going to talk about today. These 5 keys to making sure that that return happens with your program. The 5 keys are culture change management, standardized and directive policy, monitoring technicians, program management structure, and quality and performance. So let's dive in. Culture change management. We've all heard this before. There are many, many, many different models. I just have one example of one pulled up here. You can't bring in a new program and expect your staff and your culture to embrace that new program unless some things are done to prepare for it. You need to understand the why and know the leader expectations for this change. The why are we bringing in telesitting? What is it solving? What is the problem that we are facing? And what does our leadership expect? That is the cornerstone of a successful program. You have to know what your senior level stakeholders are expecting from this program in order to be able to build a policy and build your workflows around that, around the program to gain success. If you don't know why you're using it, there's going to be a lot of confusion, and there's going to be a lot of reasons for staff to just go back to old ways. So very, very important, top level, know your leaders' expectations. Establish goals. It's really important to establish the goals that you're trying to gain from implementing a telesitting program. So whether these goals are cost related or safety related or both, you want to know what you're working toward and why you're using that, especially the frontline users, because they're the ones that are going to have to make the decision on the uses of the telesitting program. Establishing accountability is so important as well. This is teamwork. I'm going to bring that up again and again. This is teamwork. You have to have somebody that is accountable for the results and for managing the program on a day-to-day basis, especially at the beginning, in order for you to have success with this program. And then, like I said before, prepare for effort. Now, this program is meant to create efficiencies. It's meant to save time, and it's meant to save staffing and save costs. But it doesn't come that easy. You can bring this in, and you have to work to get to those. But it is one of those programs that the more work you do up front, then the more natural it is going to become, and it will become part of your workflows and part of your routines very soon, and that work will minimize. But the care and management of it at the very beginning is very important. I'm going to talk a little bit about a directive policy. So a directive policy, when we're talking about bringing in a technology that is going to help you with some of the things that you're looking for, we need to make sure that you are creating one policy that are going to be covering all constant observation interventions, and it is going to be specific toward the goals and expectations of your senior leaders for this technology. So a change in culture means changing and adapting policies to match. You shouldn't just add a telesitter policy because you're bringing in a technology. You need to create a policy that includes telesitter as one of your tools that you can use for patient safety. And so that's what I mean when I say creating one policy. It's really important to do that. The elements of a policy are very important as well. Elements have to be standard. So let's just think a little bit about some of our deployments who are multi-hospital deployments of telesitting, where they have a central hub and they might be monitoring for patients in different locations. There has to be a standardized part of the policy, and that standardized part gives the expectations of the why and the how, and what the goals are in general for the system. And so an example would be when to use telesitting and when not to use telesitting. So that's going to be the standard part. Now, there are certainly going to be some customized parts for each site, some of the workflows, how to move the devices around, where they're stored, how they're cleaned. Of course, that's all going to be site specific, but it's very important to have a very clear and concise standard language on your policy for when, how, and why to use telesitting. You're also going to want to establish clear criteria for the type of constant observation that should be used in the scenario. And you want to have a gatekeeper process. Your goal here is to meet the goals. If your goal is to lower sitter costs, the only way you can do that is stop using sitters. And if you don't stop using the sitters for the appropriate reasons, you're going to maintain that sitter cost. And at times, you're going to need a gatekeeper to make that decision for your staff. Your staff is used to doing what they've been doing, and they might need a little bit of coaching and a little bit of a leadership kind of getting involved and saying, nope, this patient meets the criteria for telesitting. We're not going to use a sitter for this patient. We're going to use telesitting. And that is going to really help you establish that expectation for when and how to use telesitting. And that comes from the policy, and it has to be clear and concise. You're also going to want criteria for exclusions and reasons to not use telesitting. There shouldn't be many, because telesitting should be used based on a behavior assessment at the time of need. But there are going to likely be some, and you'll have to talk about that. You're going to want clear criteria for an assessment and a reassessment cadence. Nurses need to know when they need to reassess, how they need to document, when they need to determine if the patient is doing well on telesitting, or if they can come off telesitting because their condition has improved. And then some clear criteria for triaging and decision making. All of this is going to lead to a well-run program if you have the standard elements that I've just discussed in your policy. I want to focus on monitor technicians for a few minutes. The monitor staff can make or break a telesitting program. As you have probably all heard, and if we haven't told you, we will be telling you if you're connecting with us. We recommend that monitor technicians have clinical experience. Maybe they're at a level of a PCT or a nurse's aide or a tech. They've worked in a hospital before. They've worked with patients before. They know what behaviors to look for. They know what safety issues are, and they know how to intervene and when to intervene. It's really hard to train somebody how to do that from a remote setting into a room if they've had none of that experience. So our best practice recommendation for monitor technicians is to make sure that you are hiring or moving staff into this role that have clinical experience. It should be a dedicated role too. It is not the best practice to train a 100-person float pool on how to float into the monitor station and have them only float in maybe once or twice every month based on a rotation. There's a lack of consistency there. It makes it harder for the monitor staff to remember how to operate the system, and the monitor staff don't get to know the patients. If at all possible, we recommend that the monitor staff are dedicated to that role and are in the monitor station quite frequently, at least as their main role. The other thing is to begin the hiring plan early. If you have to hire from the outside, or if you have to deal with unions, sometimes the hiring for your monitoring staff can delay your go live of your program if you don't consider it and think about it early. And just one other point to note, there is hosted monitoring available. What that means is another service, not the people from your facility, but from a partner facility of ours, can do the monitoring for you for a price if you should choose to do that. Those monitor staff are trained, they're consistent, they're dedicated to their role, it's the only thing they do. For those monitor techs who might be listening to this presentation, I do have to thank you for what you do and your dedication. It really takes a special person to do this job, and we look forward to hearing from you. I think that there is a couple of monitor tech sessions later on in the symposium, so I'm excited to hear that. The next point here, the next key, the second to last key here, is the program management structure. Again, I'm going to kind of say that this is a team approach. The teamwork with a little bit of effort and a little bit of time is going to lead to success. You really want to have that expectation from your executive owner. Why are we using this program? What are we looking to solve? Are we looking to solve costs, safety issues, both, whatever else it might be? And that executive owner has to direct their directors to be held accountable and be responsible for those outcomes. So the director and or a manager of the program or that is assigned to be accountable needs to have involvement on a day-to-day basis with this program, especially at the beginning, to massage it and get it to the workflow that you want it and the cadence that you want it. That gatekeeper, here that gatekeeper comes up again. It's really important. The gatekeeper doesn't have to be a person. It can be a role. Maybe it is a nursing supervisor, or maybe it is a charge nurse, or maybe it's somebody in the admissions office. It just has to be somebody that consistently, Monday through Friday, on the weekends, evening shifts, night shifts, every moment, there is somebody that is upholding the policy and making sure that the bedside staff are following the policy and not using sitters when they shouldn't be, or putting the devices on patients that don't really need them, so on and so forth. Part of that team is the monitor staff. They're providing the service, they're providing the monitoring, they're part of the care team. They're working with the bedside staff to keep that patient safe. And so the monitor staff needs to be managed appropriately. They need to have consistent education opportunities, and they need to be, like I talked about before, dedicated. The bedside staff are an important part of the team as well. They need to understand the why. Why are we using this? How do I use it? And they need to know when to assess the patients to make sure that the intervention is still appropriate, or that they need to make some decisions for other options. That bedside staff is part of the team. That communication between the bedside staff and the monitor staff is very important. And that has to be one of the responsibilities of the director and manager as well, to ensure that that communication component is working well. And then, of course, the patients, they're part of the team too. The patients, their job is to remain safe. And we want to ensure that the patients who are chosen for this system understand the system, understand why it's there, there's signage in the room, and that they stay safe. The last piece of this is quality performance. You can't build a program, you can't get a program going without measuring the outcomes and measuring the quality. And this is really important. This is something that is kind of up my alley. It's the data tracking, outcome, and tracking analysis to ensure that you are meeting the goals and the expectations that were set. You can't improve what you can't measure. So it's going to be very important to marry the program metrics that you get from the ORNA database with your hospital outcomes, such as your sitter usage, your falls and numbers and fall rates, your falls with injuries, your line and tube dislodgements, your elopements, whatever you want to measure. But you have to measure both, and you have to look at them together so you can ascertain that the program that you are building and managing is impacting the outcomes that you're looking for to get, whether it's cost savings or improvement in safety. That is how you're going to determine if you're getting a return on investment. Also know that AvaSure offers regular work with our clinical team. We have clinical experts that will work with you on a regular basis to review your utilization and your program performance. We also provide annual staff education and support for you to do that as well. E-learning modules and on-site education as needed. And another thing that you can do is research. If you have any inkling or any need to do a research project on this application, connect with us and we'll help you with resources for that. But research can be a great way to lead you into measuring your quality as well. I could go on and on. I need to get to some questions. So I'm going to stop sharing my screen now and get back into the room. And I would like to open this up for any questions that you may have. Okay, wow, we've got a lot. Let's see. How many patients can one monitor staff watch? That's a great question, and that feeds right into a return on investment. One of the things that I forgot to say was our kind of catchphrase, one-to-many monitoring. It's so obvious that one-to-many monitoring is so much more cost efficient than one-to-one monitoring. So for the telesitter solution, our software holds on each screen or each license where you're sitting in front of up to 16 views. Our average monitor tech across the country usually is watching about 12 patients at a time, but the maximum they can hold is 16, so you can flex up if needed. And it looks like Jennifer said that your ratio at your hospital is 1-12. So thank you for answering. Oh, it looks like a lot of people answered those questions. Great. How is this tool utilized for fall prevention? So fall prevention, that is one of the key return on investment expectations that a lot of leaders expect. And fall prevention with telesitting is accomplished through immediate audio redirection to the patients. Now, you have to get the right patients on the system. And so we're going to help you with that as you figure out using fall risk assessment tools or any tools that you have currently in use in your hospital, maybe BPAs from Epic or maybe triggers from some previous event. And we're going to help you establish that criteria to try to pick the best possible patients for the system that are at the highest risk for falls or falls with injury. Once you get the devices to those patients, then you're going to be able to use the system to interact with those patients, to immediately intervene, to communicate with the bedside staff when they have needs, and to set off a stat alarm for urgent response within about 15 seconds if there's an emergency in the room. That is really how it's in a nutshell, how it is used for fall prevention. For effective dents in your fall rates, we typically see a hospital starting out at about 10% coverage of their average daily census beds and growing from there. A 100-bed hospital would benefit from 10 monitoring devices or more. Any other questions? That looks like the end of the questions. We have about 4 minutes left. I don't know if we want to back out and go into chat rooms or if we can open this up for a chat, or if the leaders of the symposium want to give me some direction on where to go from here, but I don't see any more questions. I appreciate all of you joining. And I think what I'm going to do is just make this executive decision here, and we're going to go back to the chat room. Oh, thank you, Jennifer. Just in time. I'd like to hear about the gatekeeper role, especially with the bedside staff engagement. Thank you for that question. It's so important. The gatekeeper role, the best way I can describe it is this is the role or the designated person that upholds the policy. And the policy is going to be the directive that is going to point staff in the direction of when they should use telesitting, why they should use it, and how they should use it in order to meet their goals. And so the gatekeeper, by upholding that, is going to be the one that is going to say, no, you can't have a sitter because this patient, according to our policy, says that you can put telesitting on this patient first. Now, you may have something in your policy that will help you make decisions once that patient is on telesitting if they're not doing well on telesitting, or maybe it's just not, the patient is too busy on telesitting and it's taking away time from other patients. But the gatekeeper has to be involved, and they may be the ones that have to dole out the sitters and dole out the telesitters until everybody gets used to it. If in our experience, if you don't have a gatekeeper and you leave it up to the bedside staff to request a sitter and there's nobody gatekeeping that sitter request, you're going to still use sitters that you don't really need to be using, and your costs are not going to be as impacted as much as your goals and your expectations state they should be. So hopefully, Jennifer, that answers your question. How do you know when not to use a sitter versus a video monitor tech? You're going to know that through the development of your policy, The clinicians at the bedside are going to be assessing the appropriateness of the patient. It's going to go through, of course, that gatekeeping process. And then there may be a protocol within the policy that will help you determine if that patient should remain on telesitting or for some reason should not remain on telesitting. So it's going to be part of that inclusion and exclusion criteria and bedside nurse assessment. Do most of your clients set up programs themselves or use hosted models? Most of our clients, the majority of our clients, set up the programs themselves. The hosted models are relatively new, and the partnerships we have are relatively new, and so it is now becoming more available, especially as we are seeing the industry shift into challenges with staffing and keeping staff. This is becoming more and more of a need. So right now, most of our programs have their own monitor staff, but you do have the opportunity to have a hosted model. Lisbeth, thank you. Lisbeth added a link for Tony for a really good article on how the system is used for fall prevention. We do have a lot of evidence-based articles that and publications. If you go to the avasure.com website, you will find a wealth of information on all of these issues and all of these criteria. So visit there. Thanks for posting that, Lisbeth. How do you quantify savings from events that don't happen? Cost avoidance or events prevented. It's really hard to quantify savings with a dollar amount. You can work with your leadership to determine how you want to do that. So some of the things we've done in the past with our partners is help them set up a cost avoidance calculation where you would determine what you would have paid had a sitter been used for that particular patient and add that all up, and you can get a cost avoidance calculation. You could also look at the sitters and hopefully the numbers of sitters going down and cost savings for that. And then as far as for events that don't happen, we do have in our ORNA database a way to measure potential events prevented. And I think, Kelly, I might be getting signaled that we have to stop for the end of the discussion, but I could talk about this for hours too. So feel free to email us and we'll talk a little bit more about that. But the monitor staff can document events that they feel that they have prevented with their interventions, and you can begin to start quantifying those prevented events through counts based off of the ORNA database that's connected to the system. And lastly, Ileana, a hosted model means that your staff is not doing the monitoring, but you're entering into a partnership with a company who provides the monitoring for your patients from a remote location, and they are not employees of the hospital. Okay. Thank you all so much. I do have one announcement for moving on. We'll be taking a short break, returning at 1 o'clock Eastern Standard Time for the next session. And the next session is Change Agents, Managing Innovation to Achieve Results. So we hope to see you back for that. Thank you so much for your time and for your participation. It was really, really fun interacting with all of you. Take care.